Welcome to Preventive Medicine Grand Rounds for August 4th, 2021. My name is Antonio Neri from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the CDC, Preventive Medicine Residency and Fellowship, and the Health Resources and Services Administration Bureau of Health Workforce. The PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed the epidemic intelligence service at CDC or have equivalent public health experience. We use Zoom for the audio and presentation, but use the question and answer box to pose any questions during the lecture. Note you can pose questions via the question box at any point during the lecture, and the speakers will work on answering them at their discretion. Closed captioning is available at the webinar link provided in the chat. Continuing education credits are available for the live course for up to 1 month after the live presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. You can see the cdc.gov/prevmed website for more information about continuing education. Please remember that the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Today's Grand Rounds will be entitled Niosh, where Occupational Safety and Health intersects with Preventive Medicine, by Dr. Randall Nett, one of our alumni from the program. Before we start, I want to take 1 moment of silence to remember our friends, family, and colleagues who've either suffered from the disease or work hard to prevent and treat the disease from COVID. With that, I'll hand it over to Dr. Nett. The presentation will be approximately 1 hour, 30 minutes for questions and answers afterwards. Please welcome our presenter. Welcome, Randy.
Hey, thanks, Tony, and good morning and good afternoon to everybody that's attending today. As Tony mentioned, as a proud CDC Preventive Medicine Residency and Fellowship alumni from the class of 2009, it is truly an honor and a privilege to join you all today. As mentioned, my name is Randall Nett, and I currently serve as the Chief of the Field Studies Branch in the Respiratory Health Division at Niosh in Morgantown, West Virginia. And today I would like to share with you a little bit about Niosh, where Occupational Safety and Health intersects with preventive medicine. And just scrolling through the attendees today, I see several of my Niosh colleagues have joined today. So when it comes time for the discussion, I would kindly ask those folks that are joining today to please chime in with any thoughts that they might have, because I certainly do not pretend to know all that goes on at Niosh. Okay. So I have quite a bit of material to go through. We're not going to be here for the full hour, I don't think. We'll be a little bit shorter than that, but I do want to cover the following topics. This talk is really broken down into the first 6 bullets, and then after that is the 7th bullet. So the first 6 bullets, I'd like to cover the work-related morbidity and mortality and why Niosh exists. I also want to talk about the importance of the Occupational Safety and Health, or the OSHA Act. I want to clarify some differences between Niosh and OSHA. I'm also going to talk about the Niosh locations, divisions, and organizations, because I really feel like we need to understand that to get a full understanding of the breadth of work that goes on at Niosh. Also want to touch on key Niosh programs, and no discussion of Niosh would be complete without discussing the hierarchy of controls. And I think for me, the most interesting part of the talk is towards the end, which is providing some preventive medicine examples at Niosh. So we all know this, but I think it's worth reminding us all that, it's estimated that we spend about 1/3 of our lives at work. And in fact, an average worker will spend about 90,000 hours at work over a lifetime. So just stop and think about that for a moment, about all that time spent in work and how much of an impact a work environment can have on a worker's health. Both positive, so there's positive outcomes of work, including a sense of purpose, an ability to provide for your family, a sense of community, and a sense of contribution to your community. But there's also negative consequences as well. And I want to turn to some of those negative health consequences of work. So this figure depicts the burden of non-fatal workplace injuries and acute illnesses using the Bureau of Labor Statistics, or BLS data. So in this figure, the number of cases in millions is shown in the blue bars on the left y-axis, and the incidence rate per 100 full-time workers is shown in the green line and on the right y-axis, and the year is on the x-axis. And we can see from this figure that the rate of the burden of non-fatal workplace injuries and illnesses is quite substantial. Also want to highlight and emphasize that these data only include private industry and not the nearly 21 million workers who work in local, state, or federal government. And from these data, we see that there were nearly 3 million cases of non-fatal injuries and acute illnesses in 2015, which comes out to about 3 cases per 100 workers in 2015. So fairly common. And this pie figure depicts the overall proportion of workplace illnesses in private industry in 2015 by category. And although the numbers are a bit difficult to see, if you look at the colors, we see when it comes to work-related illnesses, some are more common than others. So skin disorders, which is shown in the lighter blue wedge, respiratory conditions in the smaller lime green segment, and hearing loss in the darker blue are all common work-related illnesses. Using BLS data for fatal workplace injuries, we also see that the mortality burden is high. So in this figure, the number of deaths is depicted in the red bars on the left y-axis, and the rate of fatal injuries per 100,000 full-time workers is depicted on the right y-axis, and the year is on the x-axis. And in 2015, there were nearly 5,000 fatal workplace injuries, which was about 3.5 fatal workplace injuries per 100,000 full-time workers. And if we look closer at the data, we see that the rate of fatal workplace injuries is not evenly distributed. So this figure depicts the rate of fatal workplace injuries by state, and the states with the highest rates are shown in red. So you can see that Montana, Wyoming, North Dakota, and Mississippi all have high rates, whereas the Northeastern and the West Coast states typically have lower rates. And this figure describes the average rate of fatal workplace injuries by occupational category compared with all workers, shown in the red bar at the top. So here we see industries like transportation and material moving, shown in the top bar in orange, construction and extraction, shown in the top bar in purple, protective service, shown in the maroon bar, and farming, fishing, and forestry, shown in the top yellow bar, all have higher rates compared with all workers. And so all this to say that the burden of fatal workplace injuries and the types of occupational illnesses and injuries are not evenly distributed. And it is because of this substantial morbidity and mortality that's associated with work that the US government established agencies to help address this problem, which is why we will be spending today talking about Niosh. But before we do that, I have a question for those who have never worked at Niosh. And again, I see several folks who are attending today who are currently at Niosh. But for those of you who are not at Niosh, let's be honest with each other. So on a scale of 1 to 10, with 1 being the least and 10 being the most, how would you rate your current knowledge at Niosh? So I know the chat is disabled, so I was going to ask for answers, but perhaps it's best that I don't. I know for me, even after completing the EIS and the PMR training programs, I am a bit embarrassed to say that at the time, and before coming to Niosh, of course, I would have put my level of knowledge at that time somewhere around a 2 or a 3. And that's probably not uncommon for some of you, which is why today we're going to be talking in depth about the work that goes on at Niosh. So Niosh is the National Institute for Occupational Safety and Health. Niosh is the federal agency responsible for conducting research and making recommendations for the prevention of work-related injury and illness. And the vision of Niosh is safer, healthier workers. And the mission of Niosh is to develop new knowledge in the field of occupational safety and health and to transfer that knowledge into practice. So the current strategic goals of Niosh include the following. The first is to conduct research to reduce worker illness and injury and to advance worker well-being. The second is to promote safe and healthy workers through interventions, recommendations, and capacity building. And the third is to enhance international worker safety and health through global collaborations. So Niosh came to be because of the 1970 Occupational Safety and Health Act. So the act established the Occupational Safety and Health Administration, or OSHA, which is the government agency responsible for setting and enforcing standards. But the act also established Niosh, which conducts and funds research both in workplace settings and in the laboratory, makes recommendations, provides technical assistance, and trains occupational safety and health professionals. But one thing to know is Niosh is not OSHA. Those on the phone today who work at Niosh will concur that we often get confused with OSHA, particularly among our folks we're serving in workplaces, but we should never be confused with OSHA. It's important to understand where OSHA and Niosh are located in the federal government. So OSHA is located in the Department of Labor and is tasked with regulation and enforcement. Niosh, on the other hand, is located in the Department of Health and Human Services and is located within CDC. And as mentioned, Niosh is focused on research and recommendations. So Niosh is spread across 9 sites in 8 states. And to really get a sense for all the work that goes on at Niosh, I want to very briefly summarize what each division does at each site. While this might not be the most exciting content, I think it's very important that we understand this so we can appreciate the breadth of work that takes place at Niosh. So of course, the Office of the Director, we'll start there. The Office of the Director is located both in Washington, D.C. and Atlanta, Georgia. So our director, John Howard, is located in Washington, D.C., where he interacts substantially with Congress. The Washington, D.C. site also houses the World Trade Center Health Program Division, and the World Trade Center Health Effects Program was established by the James Zedraga 9/11 Health and Compensation Act of 2010. The program provides medical monitoring and treatment for responders at the World Trade Center and related sites in New York City, the Pentagon, and Shanksville, Pennsylvania. It also provides services for survivors who were in the New York City disaster area. In Atlanta, there's also the Emergency Preparedness and Response Office, which serves to conduct work centered around protecting responders to emergencies. There's also the Office of Extramural Programs, which serves to administer some of the research programs that we'll talk about later. In Pittsburgh, Pennsylvania, the Pittsburgh Mining Research Division, or PMRD, conducts research to eliminate mining fatalities, injuries, and illnesses across all mining sectors. And I'll just put a plug in for anybody who has not been there, but if you ever have the opportunity to tour the Niosh Pittsburgh site, I highly encourage you to do so. They have so much interesting research going on at that site. Pittsburgh is also home to the National Personal Protective Laboratory, or NPPTL. NPPTL was created to be the division of Niosh charged with the mission of preventing disease, injury, and death for the millions of workers who rely on personal protective equipment at their job. And we have obviously seen during the COVID-19 pandemic response the value that NPPTL brings to the public health fight. In Spokane, Washington, the Spokane Mining Research Division, or SMRD, works to eliminate mining fatalities, injuries, and illnesses across all mining sectors as well. But they have a focus on mining in the Western United States, which comes with its own challenges. And sharing 3 sites in Spokane, Washington, Denver, Colorado, and Anchorage, Alaska is the Western States Division, or WSD. WSD functions to research solutions to reduce a wide variety of occupational safety and health hazards. And as most likely know, the Western United States is currently experiencing a boom in population growth, and it encompasses a broad range of working environments with a variety of workplace and safety and health issues. And some of these, in some of the states, obviously, like we talked about earlier, particularly with Montana, North Dakota, and Wyoming, have high work-related fatality rates in some states. And so workers in the West can face unique climate exposures, long distances traveled to get to work, and unique exposures really, from things like fighting wildland forest fires, for instance. And then there's 3 divisions located in Cincinnati. So the Division of Field Studies and Engineering, or DFSE, they seek to prevent work-related illness through a multidisciplinary program, including worksite evaluations, surveillance research, and the development of engineering controls and interventions. The division, and we'll talk a little bit more about one of their programs later, which is the Health Hazard Evaluation Program. The Division of Science Integration, or DSI, provides recommendations to prevent occupational death, injuries, and diseases by working on certain activities like developing educational materials, for instance. And the Division of Compensation Analysis and Support provides, or DCAS, provides scientific support related to claims from workers who have certain cancers where they might have been exposed to radiation in the workplace. In Morgantown, West Virginia, where I work, we have 3 divisions. So I'm located in the Respiratory Health Division, or RHD, and here we have a multidisciplinary approach that specializes in identifying, evaluating, and preventing the spectrum of work-related respiratory diseases, such as asthma, COPD, and pneumoconiosis. We also, through the Health Hazard Evaluation Program, work to identify emerging issues surrounding respiratory health diseases, whether those be new diseases or new exposures that are causing those diseases. And then there's the Division of Safety Research, or DSR, which works to address the safety issues of the 21st century workplace. And it is the place within NIOSH that deals with traumatic injuries and deaths. And finally, in Morgantown, we have the Health Effects Laboratory Division, or HELD, and they've worked to conduct laboratory research to better understand occupational diseases. For instance, some of their work, in the past, in the Respiratory Health Division, we've identified potential exposures associated with lung disease, and then in HELD, they can do further work, for instance, developing animal models to investigate those hypotheses. So NIOSH is made up of multiple centers that focus on research activities in specific areas of study. So these include nanotechnology research, occupational robotics research, motor vehicle safety, workers' compensation studies, direct reading and sensor technologies. So you can think of here like heart rate or certain things coming from your exhalation, for instance. We have a productive aging and work center, and we also have a maritime health and safety and health studies. And so a lot of the work that goes on at these centers is really on the cutting edge, and it's these centers that are driving kind of the work in these specific areas. And one of the most important activities at Niosh is occupational safety and health research. And as part of this effort, Niosh coordinates the National Occupational Research Agenda, or NORA. NORA provides a framework for stakeholder engagement, and in short, councils for each industry sector. So you can see the major industry sectors are located on the left, for instance, construction or healthcare and social assistance or services. All the major industries are represented. And then there's also cross-sector councils by major disease or injury areas. For instance, hearing loss or respiratory or healthy work design and well-being. And research priorities are placed in a grid patterns, if you will. And so where the research priorities are placed into an industry sector and a corresponding cross-sector. So once those priorities are established, then applicants can apply for intramural or extramural funds based on those research priorities. As an example, let's consider a research priority that has to deal with breathing issues in healthcare personnel. And we'll touch more in detail on this particular issue later. But as you can see, this falls into a particular square on the grid that aligns with the healthcare and social assistance sector and the respiratory health cross-sector. So here, because there is reason to believe that dental personnel might be at high risk of interstitial and fibrotic lung diseases, a research goal was jointly created by the Healthcare and Social Assistance Sector Council and the Respiratory Health Cross-Sector Council. So now intramural and extramural grants can be written toward that goal, and that is exactly what has happened in this case. We've had 2 projects recently funded that address these goals, and in so doing, Niosh is working to address the health issues in this particular patient population, which is dental personnel. Niosh also administers multiple extramural programs, and so these include investigator-initiated research, also multidisciplinary centers, including agricultural safety and health centers, the National Center for Construction Research and Training, total worker health centers, and education and research centers, or ERCs. Niosh also works to conduct occupational safety and health surveillance in 26 states. And speaking of specific health or programs at Niosh, one congressionally mandated activity at Niosh is the Coal Workers Health Surveillance Program. And you can see a picture of the coal van, one of the 2 coal vans that Niosh has in the picture on this slide. So the Niosh Coal Workers Health Surveillance Program studies the causes and effects of respiratory diseases related to coal mine dust exposure and provides vital health information to coal miners through health screenings and surveillance. And again, this is a congressionally mandated program. And in part, the concern, or this program was actually established to prevent early coal workers' pneumoconiosis, also known as black lung, from progressing to a disabling disease. And this particular disease and our effort to control it is in large part why the Niosh campus exists in Morgantown, West Virginia. So the coal team, which goes out into the field, and they travel to mines using that van, and they provide services to the miners, including periodic chest x-rays, spirometry, and screening for symptoms related to black lung disease. The program also administers the B-Reader program. And so the B-Reader program is a program where clinicians can undergo training to learn how to read in a standardized way chest x-rays for pneumoconiosis. And so the program also works on training clinicians for the B-Reader program, making sure they're adhering to the standards that requires, and conducting some research around that program. Niosh also conducts respirator certification. And so, as we all know, respirators are critical in protecting workers in numerous workplaces. This has, of course, been highlighted during the COVID-19 pandemic. And apart from COVID-19, or before COVID-19, there were 3 million US employees in approximately 1.3 million workplaces who were required to wear respiratory protection. I imagine that number is way higher now during the COVID-19 pandemic, even for instance, in our workplace. And Niosh plays a critical role by certifying respirators for both function and safety. And this is, of course, work done out of MPPTL. Now let's talk about my favorite personal program, Niosh program, which is the Health Hazard Evaluation Program. And the Health Hazard Evaluation Program is administered out of the Health Effects Technical Assistance Branch, or HETAB, in Cincinnati, with an assist in from the Respiratory Health Division and we in the Field Studies Branch in Morgantown. And I was going to ask for a virtual show of hands, but I'm not sure that that's possible at the moment. I was going to ask how many people have heard of the Health Hazard Evaluation Program that don't currently work at Niosh, because it's surprising how many folks actually don't or have not heard of the Health Hazard Evaluation Program. And in many ways, you can think of these as EpiAids or outbreak investigations in workplaces, but health hazard evaluations can be requested from employers, workers, or worker representatives to have Niosh investigate workplace hazards and related health conditions. We can also, the Health Hazard Evaluation Program can also receive technical assistance requests from state health departments to assist in investigations in their state. And when we do these, when we go into workplaces and conduct health hazard evaluations, we typically conduct confidential interviews, often perform medical examinations, we conduct exposure assessments, and all that information is used to make recommendations to improve the health of that workforce, oftentimes through engineering controls and other ways, which we'll talk about in just a second. And speaking of controls, any discussion of Niosh would not be complete without mentioning the hierarchy of controls. So in occupational health, the hierarchy of controls is a framework that describes methods of controlling occupational hazards. So this approach groups actions from the most effective to the least effective by their likely effectiveness in reducing or removing hazards. So here, elimination is physically removing the hazard and is the most effective approach. But again, this is not always possible. Substitution is replacing the hazard with something else that's less hazardous. And substituting hazardous processes or materials also often reduces hazards and protects employees more effectively than other approaches. Engineering controls are when we isolate people from the hazard. So engineering controls reduce employees' exposures by removing the hazard from the process or placing a barrier between the hazard and the employee. So importantly, engineering controls protect employees effectively without placing the primary responsibility of implementation on the employee. Administrative controls are when we change the way people work. So this refers to employer-dictated work practices and policies to reduce or prevent hazardous exposures. It's important to note that the effectiveness depends on employer commitment and employee acceptance. And regular monitoring and reinforcement is necessary to ensure policies and procedures are followed consistently by workers. So the least effective means for controlling hazardous exposures is personal protective equipment, or PPE, even though PPE is often the first method of control people will think about. So the proper use of PPE requires a comprehensive program and a high level of employee involvement and commitment. There's also supporting programs that are needed, such as training, change-out schedules, and medical assessments that might be needed. And I want to emphasize that PPE should not be the sole source of protection. Other methods listed above it in the hierarchy of controls should be used when possible, and PPE should only be relied upon until those other more effective methods can be put in place. So in summary, for the hierarchy of controls, in most cases, the preferred approach is to eliminate hazardous materials or processes and install engineering controls to reduce exposure or shield employees. And until such controls are in place, then, or if they are not effective or feasible, then administrative measures and personal protective equipment might be needed. Okay, so that was fairly quick, but I tried to be as comprehensive as possible with a description of Niosh. But I think after doing that, I think it's interesting to go back and turn our attention to the figure that describes the incidence rate of non-fatal workplace injuries and acute illnesses in private industry that I showed you earlier. So you will note that the data on this figure began in 1973. Now let's add in the fact that Niosh and OSHA began operating in 1971 following the passage of the Occupational Safety and Health Act of 1970. So one can make a strong argument that the Occupational Safety and Health Act of 1970, which led to the creation of both OSHA and Niosh as federal agencies, and the important work that followed led to a dramatic reduction in non-fatal workplace injuries and acute illnesses since their creation, and in so doing made our workplaces much safer. So now let's get a little bit more specific about some of the work at Niosh and how this work relates to preventive medicine. And as you all know, preventive medicine has three subspecialties that are shown here. So that's public health and general preventive medicine, aerospace medicine, and occupational medicine. And for the remaining part of this presentation, I'd like to focus on the highlighted area, that is the intersection of occupational medicine and public health and general preventive medicine. So I was thinking about this topic just recently because just this January, and time sure flies by, but I had to renew my board certification. So as part of this process, I underwent a competency assessment, which meant that I reviewed each of the 33 competencies of the American College of Preventive Medicine and provided examples of the work I did at Niosh for many of these competencies. And what I found, at least for me, is that my work applied to each of the ACPM's competencies that were common to all content areas. I also found that my work aligned with at least one of the ACPM content area specific competencies in each focus area, which includes, of course, biostatistics and epidemiology, management and administration and medical management, clinical preventive medicine and occupational and environmental health, and the ACGME general physician competencies. So all this to say is that preventive medicine can be and is practiced at Niosh. So now I'd like to focus in on a few examples of how work at Niosh actually aligns with preventive medicine practice. And the first topic I'd like to touch on is dental personnel and idiopathic pulmonary fibrosis, or APF. And just as a brief summary, most of you probably know, but idiopathic pulmonary fibrosis, or IPF, is a rare lung condition, but in a lot of ways, sometimes it's better to be diagnosed with certain cancers than it is IPF. IPF has a median time from diagnosis to death of about 3 years, and it's at present no cure, and it's just kind of a rapid decline in the ability to breathe. It's really it really is a devastating disease. But just to orient folks, there are a lot of dental professionals in the United States. So according to the Bureau of Labor Statistics, about 767,000 dental professionals worked in the United States in 2020. So about 95% of those workers were dental assistants, dental hygienists, or dentists, and about 5% were dental laboratory technicians. And those And those 767,000 dental professionals perform a multitude of tasks as part of their daily duties, with each task creating its own set of exposures that can potentially affect the respiratory system. These tasks vary from things like performing routine dental exams and cleaning, taking x-rays, polishing dentures, grinding dental prostheses, and using anesthetic gases. And I just want to stop for a moment it's a bit sad, but it's also fairly, it's probably true of life. But these are all stock images that I got, and nearly at least, let's see, 3 of these, you can see that there's no personal protective equipment being worn in the top right. The bottom center, they're using surgical masks inappropriately. They're not covering their nose, and the surgical masks don't protect you from the exposures that they're likely encountering in their tasks. In the top left, he also has a surgical mask, but it's only over his mouth and not over his nose. So this goes to show you we have a long way to go with making sure that people wear their appropriate personal protective equipment and wear it appropriately. And also goes to show you why the personal protective equipment is at the bottom of the hierarchy of controls. But let's move on. So the question is, what do we know about the health outcomes among dental professionals that are the result of these numerous occupational exposures? So we at Niosh first became interested in the association between idiopathic pulmonary fibrosis, which again is a relatively rare and severe lung disease, and dentistry when in April of 2016, we received a call from a dentist who was undergoing treatment for IPF. And he let us know that he was aware of at least a few other dentists who had undergone treatment for the same condition at the same IPF treatment center. So then, of course, we contacted the treating provider, and we eventually collaborated on a project to describe their clinic's experience treating dental personnel. So our investigation began by reviewing the electronic medical records for all 894 patients with an IPF diagnosis who had been treated at this IPF treatment center during September 1996 through June 2017. So we worked to identify patients known to be dentists, dental hygienists, dental technicians, or dental assistants. We then abstracted those relevant medical records, and when possible, we conducted interviews with the living patients and performed a descriptive analysis. And we ended up identifying 8 dentists and 1 dental technician among the 894 patients treated at this center. And when we considered the proportion of dentists in this population compared with the proportion of dentists in the general population, we estimated the number of dentists to be 23 times higher in this patient population than what we would expect. Coincidentally, following the publication of this MMWR, it so happened that right after that, 2 additional dentists began undergoing treatment for IPF at the same treatment center. So this meant that out of now 899 patients undergoing treatment for IPF up until September 2017, that 10 of those patients were dentists. So the identification of 2 additional dentists meant that the number of dentists treated was now 29 times higher than the number expected. And despite the limitations of this case series, other data we have indicate that dental professionals might be at higher risk of acquiring IPF. So data from Niosh's National Occupational Respiratory Mortality System indicate that those who worked in dental offices and dentists have higher IPF-related mortality compared with the general population. So based on all of this, we were left asking whether dentistry-related exposures do in fact result in pulmonary fibrosis. So to address some of these issues, we've undertaken a few studies to help evaluate interstitial lung disease morbidity and mortality among dental professionals. And what I'm describing here is one of the 2 successfully funded projects that we were able to get funded through the NORA system, or the NORA program that I described earlier. So the first is we have partnered with the American Dental Association to identify the causes of death for over 49,000 dentists who died during 1979 through 2018. And this will allow for a comparison with the general population of the likelihood for mortality caused by both non-malignant and malignant respiratory diseases, and a calculation of proportionate mortality ratios. Next, we have partnered with 8 IPF treatment centers to identify dental professionals treated at each center. This will allow for a description of the clinical characteristics of the dental professionals, and will also allow us to calculate a prevalence ratio, that is the dental professionals to non-dental professionals, and make an estimate whether that ratio is higher than expected, similar to what we did at the Virginia Treatment Center. And finally, for those dental professionals identified at the 8 IPF treatment centers for whom we identify available biopsy or explant tissue specimens, we would like to obtain those specimens for additional analyses to include things like polarized light microscopy, enhanced dark field microscopy, scanning electron microscopy, and energy dispersive X-ray. And so these techniques will actually allow for an evaluation and a characterization of dust particles located within the lung tissues of these dental professionals undergoing treatment for their pulmonary fibrosis. And it's our hope that this collaborative investigative work will help further our understanding for the risk of respiratory disease-related mortality, morbidity and mortality in dental professionals, and going back to how this relates to preventive medicine. So all of this work will then hopefully allow for better understanding of what this particular patient population, so if we think about our patient population as dental professionals, what kind of breathing conditions that they're at higher risk for, and what we can do to make their workplaces safer over time. The second example I would like to give is about, I'd like to talk about occupational data for health, or ODH. So occupational data for health, or ODH, is designed to take advantage of information technology or IT system features to improve worker health by supporting patient care and public health surveillance. So the focus of this team working on this issue has been on first improving patient care, improving care in the primary care setting, and the second is supporting data collection for public health. So as far as improving care in the primary care setting, this information can be used to support prevention, diagnosis, management, and treatment, and can be used to manage specific patient populations that we identify, and we'll touch on that in just a second. Also can be used to support case reporting and submission to cancer registries. This work will also enhance our surveillance data collection and hopefully help mitigate outbreaks in the workplace and identify and monitor work-related conditions. And as an example for mitigating outbreaks in the workplace, if providers on, let's say, 2 different sides of town both see independently, and let's say these 2 providers, let's say, are in the same system, but they're working independently, they may see, independently, they may see workers from the same workplace who have the same condition. And by using the information in that electronic health system more, I guess, better using that information, we may be able to identify clusters of disease or outbreaks at particular workplaces that would go unnoticed normally. So some specific examples demonstrate the utility of occupational data health in primary care. So for example, diabetes can be more difficult to manage in the setting of a rotating schedule with nights or evenings. And the recognition of a challenging work schedule for a patient by the provider creates opportunities for education and perhaps the ability to make a request for reasonable accommodations so that that person's diabetes can be better cared for over time. Niosh has also done work to facilitate the use of work information to guide clinical care by developing approaches to clinical decision support. And one such effort is available on the AHRQ website for use by developers to improve diabetes care. And with structured information in the record, a clinician or practice can look for patient populations who share common occupations or industries. And so this creates opportunities for prevention interventions at the point of care. So for instance, You could provide housekeepers with educational materials in their primary language on lifting to reduce back injuries. You could provide house painters information about exposure to lead, and you could then make sure to screen house painters for elevated blood lead levels. You could talk with healthcare providers for your patients about stress. You could conduct appropriate screening for patients at risk for silicosis, and the list is endless, really. You could, I think the bottom line is just considering somebody's work exposure in the system and knowing how to act on that information will both help you identify patient populations and hopefully care for them in a way that reduces their morbidity and mortality within that population. A final specific example of the purpose of occupational data for health is the use of these data for public health reporting. So for example, these data can provide usual industry and usual occupation cancer registries to further research and understanding of the linkages between work and cancer. They can also provide current industry, occupation, and employer address with electronic case reports, again, to hopefully recognize sooner workplace-related outbreaks. And finally, they can identify patients with reportable conditions, such as pesticide poisoning in an agricultural worker or a rare occupational lung disease or several other things. So overall, I think occupational data and health work in electronic health systems is really an exciting frontier for us. And hopefully, the folks working on this at Niosh can really improve patient care in the primary care setting. The third example I want to highlight is safety in healthcare. So I want to define a few terms, so hang with me here. I want to define a few terms as these can be a bit confusing. And these next two slides I borrowed from Dr. Dave DeJoy from the University of Georgia College of Public Health. And the first is organizational culture, which are the values, norms, and beliefs that organization members come to share through direct experience, social interaction, and symbolic means, such as things like through stories. Safety culture is defined as the values, norms, and beliefs that a particular group of people share with respect to risk and safety. And safety climate is the shared perceptions among members of an organization concerning workplace safety. And this happens to be a leading indicator of safety performance for an organization. So this slide is intended to demonstrate that an organization's culture contributes to the safety culture. That is, an organization that does not prioritize safety will likely have a safety culture that is lacking. Likewise, an organization's safety culture contributes to its safety programs and practices, which ultimately contributes to its safety climate. But you can't get to a high-level safety climate without first having the foundational structure of a sound safety culture. And safety culture and climate are very important when it comes to healthcare professionals. And I think, again, this is another one of those topics that has really come into focus during the COVID-19 pandemic. One example of work in this area at Niosh was a survey of healthcare professionals that assessed health and safety practices of healthcare workers. So this survey was launched to better understand the circumstances to which healthcare workers may be exposed to hazardous chemicals. It was also a way to gauge how well best practices were being used to minimize exposure and to evaluate barriers to using personal protective equipment and other exposure controls. And we obviously don't have the time here, but a Niosh website allows you to view the results of the survey from the over 10,000 respondents by study finding category. The website lists key findings and provides employers with recommendations for how to improve worker safety practices. So for example, one of the findings was that only 47% of respondents reported always using local exhaust ventilation during laser surgery, and only 14% reported always using local exhaust ventilation during electrosurgery. So in response, a key recommendation was to have employees use a local exhaust ventilation system for all procedures where surgical smoke is generated. Another key finding of this study was that there were key differences that existed in safety climate perception by healthcare worker, work schedule, and workplace characteristics. So the study demonstrated that the groups with the most positive mean safety perception scores included dentists, workers who were salaried or paid on a fee-for-service basis, and workers with 1% to 50% of their time providing patient care. However, the groups with the most negative mean safety perception scores included employees working 12-hour shifts or variable shifts, those who worked mandatory overtime, evening and night shift workers, and contractors. And to address these safety climate issues, we can apply the hierarchy of controls in the context of total worker health as shown in this figure. So that is, we can eliminate working conditions that threaten the safety, health, and well-being of the workforce, and this is the most effective control. So of course, this is not always possible, but this would be the most effective control. If elimination is not possible, then we should substitute health enhancing policies, programs, and practices. We can also consider the redesigning of the work environment for safety, health, and well-being. We should also educate for safety and health. And the final thing, and this is akin to personal protective equipment, we can encourage personal change, such as let's say meditation and other stress relieving techniques. However, we should not put the burden of protecting workers in a total worker health environment. We should not put that burden on the individual worker by encouraging them to make personal change. We should instead think about controls, and this can be true, let's say for healthcare workers. This can also be true for public health practitioners. And there was an MMWR report that came out about this past summer, or this spring, that came out about the overall well-being of the state, tribal, local, and territorial public health workforce. And there were some very concerning findings in there. And those findings, for instance, could be a call for action on how to redesign how we implement public health practice in those settings, as an example. But again, we should not place the burden of changing on the individual worker. We should think about how to have a safer workplace. So when discussing controls in a healthcare environment, one critical point that we must understand is there is an undeniable relationship between worker safety and patient safety. And what we are looking at is the intersection of worker safety and patient safety, again, with the ultimate goal of improving both worker safety and patient safety. That is, we should not focus on one of these goals without considering the other goal because they are related. And we have seen examples where healthcare, and this is an example, we've seen where worker safety wasn't taken into account at the expense of improving patient safety. So we've seen examples where healthcare facilities have chosen a new cleaning product that helps eliminate healthcare transmitted infections like C. difficile, only to find that that same product intended to improve patient safety actually caused respiratory illnesses and symptoms among the exposed employees. And this product is, so you might all be familiar with the fact that many healthcare institutions over the past several decades to address healthcare acquired infections have used bleach to remove things like C. difficile, for instance. But the problem with bleach is it breaks down furniture very quickly. So it can be a huge expense to a hospital, for instance, to have to replace expensive furniture. So they were looking for other products to use, and many of these facilities chose a quote unquote green product, which is hydrogen peroxide and peracetic acid combination product. And that product, again, it's a green product. But what we found is, while it does do a good job in eliminating things like C. difficile, workers began reporting respiratory symptoms related to its use in the healthcare facility. And we learned of this through the health hazard evaluation program. And we've actually responded to several health hazard evaluations related to this cleaning product. And we've made key recommendations that will, over time, help improve worker safety. In another example, attention to worker safety through the use of personal protective equipment, such as powered purified air respirators, could in some situations negatively impact patient safety by making it more difficult for staff to communicate and errors could be made. So when making recommendations to protect healthcare workers from infectious agents, for instance, we also need to be mindful of the impact those recommendations can have on patient safety. So at Niosh, we really see two patient populations in a healthcare environment, if you will. We see both workers and healthcare patients, and both must be considered to decrease the likelihood for unintended consequences in either group. So it's my hope that through these three examples, we this is just a small fraction of the work that has occurred at Niosh recently, but hopefully those provide just a glimpse of some of the projects that we work on that fall under the umbrella of preventive medicine. So to summarize, Niosh plays a critical role in protecting the health of a key patient population, and that is the nation's workforce. And if we remember that nearly 1/3 of our life is spent at work, there's no way that we as healthcare providers, either for an individual patient or a larger patient population, should forget that much of our time is spent at work and a lot of exposures occur at work that could negatively impact our health. Which means that assessing and mitigating the occupational exposures that impact the health of our patients is critical to both delivering quality preventive medicine and protecting the public's health. And ultimately, it starts by, first of all, thinking about work and thinking about what a worker is exposed to. And with that, I'll stop. Thank you very much.
Thank you, Randy. That was super cool. I really enjoyed it. I think some of you might have been on earlier, but Randy and I were talking about Niosh, and one of his responses was that the Niosh is sort of a boring topic, but I think it's actually quite opposite of that. I think it's one of the most interesting topics because so much of your time is spent at work. There are so many different things that go on at work that could be beneficial or detrimental to your health. And it's just not an area we know so much about. So thank you so much, Randy.
Hey, Tony, can I make a quick comment on that?
Please.
And this is probably too much information, but my connotation, and I used to be in the Air Force, and I always kind of viewed occupational medicine as kind of a boring topic, mainly because the folks I was treating in the Air Force typically were young and healthy, and I probably wasn't professionally mature enough to recognize a lot of the occupational risk that they did hold. And I thought, like many people probably at my age at that time, medicine probably thought infectious diseases were, a bit of a sexier topic and more interesting. And it wasn't until I came to Niosh that I really appreciated not only the what kind of a burden a workplace can have on an individual as far as exposures and health over time, but also how interesting the science is that's practiced at Niosh, and also the impact that Niosh has on our patient populations, which are the nation's workers. And I think that was evidenced by that figure I showed that has shown a decrease in the rate of illnesses and injuries over time. And there's also a decrease in fatal injuries over time as well. And so I think Niosh unfortunately gets undersold as a quality place to work and make an impact. And I think you all need a better messenger for Niosh to make it appear more sexy than me. But it is I think, just as sexy of a topic as infectious diseases, and plays a crucial role in improving the health of our patient population. So I'll stop there.
I'm truly grateful you're here. I very much appreciate your message. I think you're the perfect messenger. There's some questions in the question and answer box. I'll give you a second to look at them. But I was working in the CDC Occupational Health Clinics back in April of 2020, doing care provision. And one of the topics that came up is that occupational health never was as a sort of like Randy was talking about. It's always sort of regarded with not as much luster or sexiness, if one will, clinically. But boy, coming COVID, when you have to decide whether people are coming to the office or not, and their exposures and all those things, I think occupational health is much, hopefully more highlighted and more appreciated in this time period.
Oh, absolutely. And there's a couple people on the call that I see have joined who I will not name by name, but have made as much of an impact on this response as anybody I can think of across the response in non-occupational related areas. And so I think, and that speaks to the fact of how important this topic is in times like this.
Certainly. I'll leave you, can you see the question and answer box on your slides?
I can, and I will offer a disclaimer that this was certainly a 30,000 foot view of Niosh, and there are areas where there much more knowledge exists in some of these areas by from some of these folks who have joined this call. So if there are specific areas that I just don't feel comfortable in, I can certainly, if we can record the question and answers, then I can I can put you in contact with a person who would know more than me. So I'll just add that as a disclaimer. Okay, so I'm just going to read a comment here. This is by Dr. Redhead, who said, as a family doc and Prev Med doc, I used to think Occ Health was rather boring too, but COVID has really changed my opinion about the power and need of workplace protections and various risks, exposures that we all have based on our jobs. And I agree with that. Thank you, Dr. Redhead. Dr. David Young would like to share the presentation. So Tony, I don't know if we can take care of that. Excellent, thank you, Krista Hale. Was talking, gave an assist, and that's exactly high five to you, Krista, for doing that. And she is providing some information to a colleague on NIOSH-funded state surveillance programs. Thank you, Krista. Dallas Shee, who's one of our newest EIS officers, and welcome to NIOSH, Dallas. She'll be in Cincinnati. She says, thank you for the great presentation. You mentioned B readers, and my question is, how can we address the shortage of B readers? Will there be more training programs? That is a tough question. So again, the B reader program is administered out of my division, the Respiratory Health Division. I am not personally involved with the B reader program, but I do know that the B readers on the whole are typically older. And so we need to recruit a newer generation. And perhaps this might be easier going forward now that there's more digital options, so it could be done at home, perhaps as kind of a side hustle. But I know the program is busy recruiting at places like the American Thoracic Society and other professional organizations. But Dallas, if you have any great ideas for how to improve the B reader shortage problem, I'm sure my boss, David Weissman, would be all ears. So please feel free to contribute any ideas you might have. All right, Tony, do you see any other questions? I'm scrolling.
Some things about, it looks like it's a difficult question, but it's about the shifting workforce of the United States and how NIOSH is working to adapt to that. Sort of comes back to, like, I would say NORA maybe.
Yeah, so there's our issues in a few different areas. And again, this is not my area, but I do know that, for instance, I forgot the technical term, but we're talking about workers who are, don't have full benefits, and seasonal workers. There's a particular term that escapes me, but there are a handful of patient populations that really need to some special attention. For me, and I see Jenny Lensman's on, so I don't know if she wants to contribute any thoughts, but as far as the electronic health records, I really see that as an opportunity for people that often are forgotten by our public health system at large, can really be identified, in the medical community and action taken to across their population to really address some of their health needs. And I don't know if Jenny has any other, if she can unmute and perhaps contribute any thoughts.
Defer to Lillian and Rich how they are able to do that. And it might be she has to put something in the chat. And there's another question that just came in on the bottom. I'll let you read about it, about jurisdiction.
Okay. So this is from Howard. Thank you for this overview. You briefly mentioned aerospace medicine as a subspecialty of preventive medicine. I was curious if Niosh works on occupational health of pilots, or if this is the jurisdiction of other federal agencies, FAA. Does Niosh have a particular list of occupations it is responsible for? So Howard, my understanding is Niosh does not have a particular list of occupations that we are responsible for. We generally work on any occupational related issues. I do know there are specific work that goes into pilot injuries and deaths in Alaska out of the Anchorage Center. I also know that there has been some work out of my sister branch in HETAB in Cincinnati that deal with some issues related to air travel. But I think, and coming from the Air Force, I know a lot more of research and work on pilots and air crews is really done in the military, in the Air Force and the Navy in particular.
Hi, Randy. This is Jenny Lensman. I'm sorry I couldn't unmute earlier, but you've articulated very well some of the benefits of having work information and electronic health records, and it would certainly provide information about gig workers and contract workers and so on, and make that information available to assess with risks, and also for the care providers to be able to discuss risks with them, which they may not get through their, who's paying them. I don't want to call them employers because so often it seems that that's not the case anymore. So we feel like getting this information into electronic health records is really going to be key to opening all sorts of avenues for helping worker health.
Yeah, thank you, Jenny, and thank you for all your work on that topic. It's so important. Okay, I see a couple of questions here. So Benjamin said, I believe Niosh and OSHA decreased a ton of workplace injuries and improved workers' health. I'm wondering about the data though. Did increasing imports from China also improve workers' health? So thanks, Ben. So I guess that's a good question. So, work in the United States in 1975 looks different than work in the United States in 2021. Certainly, there's probably more, white collar or computer jobs versus manufacturing jobs, for instance. And so, moving out of more dangerous industries to more safer industries possibly played a role. But it's hard, I guess, from my perspective, probably to tease that out a bit. But that is a point well taken. So Dr. Redhead also had a question at the bottom I see. Can you clarify public health surveillance and research organizations versus certification regulatory organizations like OSHA? Can you clarify if Niosh is both? That is in general, OSHA is typically regulatory and Niosh is typically research and recommendations. There are a couple of areas like you noted, like Niosh certifications, we also at Niosh are able to enter workplaces when there's a request made, which is not exactly it's kind of a gray area too. So there are a couple of instances that Niosh, I guess, would function in a more regulatory way, but in general, Niosh is a research and recommendation agency, and OSHA is a regulatory agency. Tony, do you see any other ones?
I don't, but I had one question based on my own sort of research interests, and I was wondering if you could talk a little bit about a shift to a more virtual care environment, particularly telehealth, and whether that's going to affect things related to Niosh surveillance.
Yeah, so that's a great question. We're actually dealing with that now, and I know I saw Reed Grimes on earlier, and he could probably possibly chime in on this, because I think he's not on any longer, but he's had his group has had the most direct experience with this recently. But because we have had travel restrictions at CDC, we've had a hard time. Basically our health hazard evaluation program, from the standpoint of doing field investigations, has been on pause since since March of 2020. So we have not been able to go out and get into workplaces like we normally would. So then that brings up, can we do more virtual visits to assess workplaces and assess workers? And that creates a whole host of challenges. You have to have adequate technology. There's logistical issues. There's issues with privacy, of course. Because some of these investigations we do are, they're fairly contentious, where workers feel like management's, risking their health. And so there's issues with, and there's issues in understanding the workplace when you can't really be there. So there's a whole host of issues, and we're still trying to work through some of those. The folks in HETAB did a virtual visit recently, but I think it was my understanding that based on their experience, this would just be a supplement at this time, and would certainly not be a replacement for entering the workplace.
And particularly in one of the things I'm interested in is the provision of healthcare through telehealth. And so as you have fewer people that are going in person for their healthcare, I think that has it might impact the information that Niosh is able to abstract off of whether people are actually getting hurt at work, quote unquote. I know that's more of a home environment now, but at the same time, with the increase in telehealth and the number of options available for telehealth, one of the things I'm interested in is the surveillance systems that Niosh has to track worker health, and whether that has been affected at all by the pandemic.
Yeah, that's a good question. I don't know the answer to that. I guess if you assume that there's no difference in the information captured in a telehealth environment between, compared with an in-person environment, then the answer, I guess, would be that the information gathered should not change. But if that, obviously telehealth is different than an in-person encounter, and it would stand to reason that the information you gather would be different in some degree or another, and that would impact the data captured by Niosh, but I'm not sure we have any clarity on that. So that's a good question.
Certainly a pretty nascent field.
Yep.
One other question. Oh, go ahead.
Oh, I was just going to mention, I see Kate, our former EIS officer here at FSB, now in the PMR program, has a question.
Yeah.
So Kate says, can you speak a bit about how Niosh communicates risk to stakeholders? For example, the dental community in IPF, with such a serious disease, does it make sense to provide recommendations on PPE to the dental community out of an abundance of caution while conducting longer-term research? So great question, Kate, and we miss you at in the field studies branch already. So I will say that that's a tough question. One thing in this case, it was a small case series, so we feel like we have to do additional work to confirm the existence of higher risk. And so we believe it's real, but we also, it could be that these people had exposures in the 1970s and 1980s that might be no longer relevant now. So we have a lot more to understand there. So that does make it hard to communicate risk. I don't think we can communicate with certainty that dentists or dental personnel are at higher risk now. But what we can do is make sure that the work practices and the personal protective equipment that they are using now are aligned with current recommendations. So for instance, if they are using chemicals where there's concern for an inhalation risk, then you don't want them simply relying on a surgical mask to protect them from that chemical exposure, because surgical masks don't protect from inhalational exposures from chemicals. So that's one example. So I think we don't have enough information to make a specific recommendation about IPF at this time, but we do have enough information about these workplaces to make sure that they're doing a better job with their basic protective practices, and for instance, a much better job than what we saw in those stock images.
And I put in a link to the Education and Research Center's portfolio, but there's a question about occupational medicine training programs. I wonder if you could talk a little bit about that, if you're familiar with the chance.
So occupational, this is from Jeffrey Levin, occupational training programs and number of trainees is waning for many reasons. Do you have thoughts on further promoting the discipline for both funding and meeting future workforce needs? So this is a great topic. I happen to be a member of the American Thoracic Society, and within that, there is an assembly. The American Thoracic Society is about 15,000, mostly pulmonologists and related researchers. But within that, there is an assembly called the Environmental Occupational Public Health Assembly, EOPH, and it seems this assembly is kind of going along with the same number of people. It doesn't seem to be growing, probably getting a bit older. And I have noticed the same thing, that we need a younger generation coming into this field. And I think it goes back to what I was talking about earlier, that the perception of Niosh and maybe occupational medicine in general is that it's not very sexy and perhaps not as important as the more glamorous fields, if you will. And I think, maybe one of the very, very few silver linings of this COVID-19 pandemic is the fact that occupational medicine really came to the forefront during this response. And perhaps because of that, that we'll see a bump in occupational medicine training going forward. At least I can hope. But as far as promotion, that's hard. I think it's going to have to occur in medical schools, with additional courses and perhaps rotations in the clinical in their third and fourth years, with an emphasis on encouraging those applicants to apply to training programs. I also think that a lot of the occupational medicine training programs, this is just me talking, need to be made as rigorous as some of the other specialty training programs. So for instance, if my thought is we should be held on the same level as a cardiology fellowship, for instance.
And certainly workforce education is one of the key components of CDC, and one part we struggle with in our own program all the time in trying to make sure we have an adequate workforce in place, and clearly that has been problematic or highlighted during the pandemic. Ongoing issue. I don't see any more questions. Did you have? I had an announcement at the end, but did you want to add anything else to close it out, Randy?
No, I just want to thank you for having me, and I think it's great that I was given the opportunity to talk about Niosh. Niosh is really an underrated place to work, and the people across Niosh are terrific, and the work they do is so important. And I would encourage anybody who, and I'm looking at you in particular, Kate and Grace, and your classmates.